Good evening, and welcome to the Psi Phi Fraternity Incorporated 2nd District Health and Wellness Monthly Webinar. I am Dr. Keith Boykin, and I'll be your host for the evening as our immediate past district representative was not able to be with us this evening. Excuse me. As you know, this webinar is where we present health prevention in the Black community. And tonight we have a very interesting topic to talk about. Actually, we have two topics to talk about. We're going to be speaking about prostate cancer awareness and blood cancer awareness month. Both of these are the awareness months for this particular month. And hopefully we'll be able to hear the stories of two people talking tonight about these two topics. Now, the ideas and topics presented here are those that are represented by the individual people and not the opinion of the Psi Phi Fraternity Incorporated. So without further ado, again, I welcome you to our monthly webinar. And this time I'd like to pass it on to Dr. Jedan Phillips, our chairman. But before I do that, I just want to remind everyone that I am Dr. Keith Boykin, and I'm a retired pediatrician and internist. So with that being said, Dr. Phillips, take it away.
Good evening. Good evening, 78. Good seeing you, my brother. My name is Jedan Phillips. I'm the 2nd District Health and Wellness Chairman. Also, I am a board-certified family practitioner and been practicing at Stony Brook University Medical Center and the Renaissance School of Medicine for the last 25 years. Again, in line with our monthly message of preventive health, tonight we're going to be talking about a topic that is particularly important to us, especially us men of color, because we are dying at a higher rate. And important part of that is getting your screening test done, knowing what to do if you do have an abnormal test, and just basic information about prostate cancer. So I'm excited for the conversation tonight and excited about the testimony because, again, when we know someone and someone that we know closely is dealing with this, their story can be very instrumental to other people.
Thank you, Dr. Phillips. So now we have each of our regular host brothers give a little bit of an introduction. So we'll start with Dr. Wingfield. Are you on? Dr. Wingfield, 92.
Good evening. Yes. Hi, good evening. I'm Dr. Edward Wingfield. I'm an interventional cardiologist. I practice interventional cardiology at Robert Wood Johnson University Hospital at Hamilton. I am the president of the medical staff. I treat all areas of cardiology, but when it comes to prostate disease awareness, prostate disease is, honestly, if you look at the numbers, African-American men are 50% more likely to develop prostate cancer. We are disproportionately affected by prostate cancer. So it is something that we certainly need to be aggressive about. We need to be educated on. So it's a pleasure. It's an honor to talk tonight and looking forward to the dialogue. Thanks.
Thank you, Dr. Wingfield. 95, Dr. Isabell, give us your introduction, please.
Good evening. Once again, my name is Dr. Lee Isabell, board certified internal medicine. I practice just about an hour north of New York City. I work at a large organization that's located in New York as well as.
Did we lose Dr. Isabell? There you go.
I'm back. So I do primary care as well as HIV primary care, as well as inpatient care. And I'll give you my perspective on prostate cancer, which also has affected my family personally also.
Thank you, Dr. Isabell. I think a lot of us have had that same personal experience. Dr. Plummer, 96, give us your introduction, please. Dr. Plummer, are you on?
I'm here. All right, now I'm on. Hi, how you doing? I'm Dr. Christopher Plummer. I'm a board certified in OBGYN and also in maternal fetal medicine. I practice out in Harrisburg, Pennsylvania. You might be wondering what I'll be able to contribute about prostate cancer, but I'm also a Black male that also can be affected with prostate cancer, and I would enjoy, listening to the advice of my fellow colleagues on this topic.
Thank you, Dr. Plummer. And last but certainly not least, is my colleague and good brother, Dr. Kelvin Ford, 05. Tell us your introduction, brother.
Good evening, everybody. My name is Dr. Kelvin Ford, and I'm a board-certified internal medicine physician practicing in Prince George's County, Maryland. Prostate cancer definitely is something that I'm very interested in. It's affected many members of my family, and hopefully we can get the word out to see how everyone can be screened and treated so that they don't have to go through any traumatic problems. Thank you.
Thank you, Dr. Ford. And you've heard many of the brothers say that, you know, many of us have been personally impacted by prostate cancer, either personally or someone in our family. I'm certainly one of those brothers that have been impacted by prostate cancer because I lost my father to prostate cancer. So before we get into the real nitty gritty of it, somebody just take an opportunity for me, please, and just tell, you know, people have heard of prostate cancer. What exactly is prostate cancer? We heard about so many times we talk about prostate cancer. Would somebody want to take a stab at like giving a general description of prostate cancer so the people out there in the audience will understand what it is we're talking about? Anybody?
I think I can just give a little, I guess, interlude in terms of the conversation. I mean, the prostate gland is the gland that sits just below the bladder. And essentially the function of the prostate gland is to produce the fluid essentially within the semen of a male. That prostate gland has, especially in certain communities, has a tendency for those cells to mutate and develop into cancerous cells. Especially with age, as we get older, those cells can become cancerous. Those cells then can kind of leak into the lymphatic system, and through the lymphatic system, it can spread throughout the body. Now, prostate cancer, as we'll discuss, is a very slow-growing cancer. So we'll talk about detection and early detection and why that's so important.
Thank you, Dr. Wingfield. There he is, folks. You heard it from a cardiologist. A cardiologist talking about prostate cancer. So you can see how important it is in our community. I mean, this brother, he practices interventional cardiology, but he can tell you exactly what is going on with prostate cancer. So I'm just wondering, when do we need to worry about when should we suspect that we may have prostate cancer? What are some of the things we might be looking at that we say, do I need to go have my prostate checked? Do I need to worry about prostate cancer? Anybody, give me a stab at that, somebody.
Well, you could have no symptoms at all. You could have changes in your urination. Now, what does that mean? That means that you may notice that the strength of your flow or the stream might change abruptly or gradually over a period of time. You might have some difficulty initiating your urination. You might have a sensation like you need to continue urinating even after you physically felt like you were done. In addition to that, you might notice some pain with urination, and you can notice blood in your urine or even blood in your sperm. And like I said, some of probably the most common symptom is no symptom at all in the early stages.
You know, I think a lot of people say, well, what are you talking about blood in your sperm? And a lot of people like, how am I going to know about blood in my sperm? I'm not looking at my sperm or anything like that. So, you know, but it's real, brothers, you know, for everybody out there. Those are some of the things you see. And, you know, a lot of things that people don't realize that with prostate cancer, you might have something simple as just pelvic pain, just simple pelvic pain, you know, pressure in your bladder area and different things like that. But before we get into that, you know, what are some of the things you guys look for? Say, Dr. Ford, for example, when someone comes in your office, what do you hear from? Who's at risk for prostate cancer? And what do you look for? What do you do when you see somebody come in your office like, I need to check them for prostate cancer? Go ahead, Dr. Ford.
Right. So the most common risk factor for prostate cancer is age. As we get older, there's a large majority of people that will have prostate cancer. And we know as African-American men of color, we're 2 times more likely to develop prostate cancer, and also 2 times more likely to die from prostate cancer. And so, you know, so we're at a higher risk. So I look at anybody that's walking in my office that's 40 and up, right? We're screening. We're going to start screening. And I know there's a lot of different variations of who you should screen. You know, people that are real high risk that are high risk start at 40. Those are who is at high risk. Someone that has a say a relative, a father, a brother who had prostate cancer. You know, you want to definitely start at 40. And I think on just about every male that of color should probably start at 40.
Yeah, I've heard the old expression, if you live long enough, you will have prostate cancer.
Exactly.
I've heard that so many times. And it's so true. But many of us just start out with something called benign prostatic hypertrophy, which is just enlargement of our prostate gland. But Dr. Isabell, I wonder, why are more people being tested for, why are more African-American men concerned about being tested for prostate cancer? Any take on that?
More African men are hopefully being tested for prostate cancer because we have shows like this to try to make them be more aware, and hopefully people are learning more about their family history. Like Dr. Ford said, African Americans are 2 times more likely to die of prostate cancer because in the past there's been a delay. We usually at times don't go until we may have symptoms because we say, I feel fine. If it's not broken, don't fix it. How many times do you hear that? Mm-hmm. Or they're concerned, hesitant about a digital exam. No one's going to stick a finger rectally, and some have fear about that. There's also some are not aware also that there's also a blood test that the PSA, the prostate specific antigen, normal range is between 0 and 4. But yes, sometimes if you have enlarged prostate, it can go up to like 10, but you have to monitor to see how it increases. If it's greater than 10, a high probability it could be cancer. And that's important to follow up. You may need a biopsy, which is a same-day minor procedure, which can diagnose if it's a cancer. But there's also other ultrasound tests that they can do, imaging, to see if there's any nodules, anything that looks suspicious. They also can do MRI. So we have advanced ways of detecting prostate cancer. And also in the past, the age was higher. If you use the government, United, their screening is sometimes 50 to 55. But like you said, when you have high risk factors, the better to do it early. I do it, start at age, usually 40, 45, but I start at least do the PSA.
That's interesting. Yeah. Let me ask you a question. Anybody, do you have to have a digital exam? I mean, I know a lot of brothers say, y'all ain't putting no finger up my rear end. Y'all ain't doing that. But do we need that? Do we need that in this day and time? Do we need that?
Well, to the brothers, I think they'll find this information helpful. Is again, in a situation where there are no, factors that may complicate things, meaning, if you just had routine PSAs annually and no digital exam, but no symptoms, and you don't necessarily, in my practice, if you could be African-American, but if you're African-American and your brothers have or father had colon or prostate cancer, I'm probably going to involve a urologist, and that's probably going to involve a digital rectal exam. So in situations where an individual might have a very high risk, I would consider it. But I think to what brothers and men will enjoy out there is pause on the enjoy. But what I mean is, what I'm happy is that you don't necessarily have to have a digital rectal exam. So don't let that stop you, because what I was going to add on with what Dr. Isabell was saying is that prostate cancer falls in this unique space of our vulnerability. It addresses stigma that we have as far as Dr. Isabell and what was mentioned. I'm not letting anybody check me like that, but it also touches on the fact that we don't have aggressive tendencies with preventive care. So again, prostate cancer is something that's slowly growing, but unfortunately, if it gets to a point where you're having symptoms, it might be a little late or might put you in a situation where things might not be as easy. The other thing that it touches on is the whole area of healthcare disparities, because unfortunately, as African Americans, and this is even if you have good insurance, we are still not always being informed about the test or the more modern therapies that are available. So again, this is why exercises like this are extremely important, because they give us the information, because unfortunately we are, even when we still go to the doctors, sometimes the information is not being given to us.
It's very, very interesting. The question in the chat is the PSA test different for Black men than white men? I don't think that there's a difference between the two of them, but one of y'all want to expound upon that? Because I think it's the same thing. It's just the older test was one type of criteria we use, and the newer test is a different type of criteria we use. And based on the new test, whether we do the next step, if he's, I know if it's under 4, you just kind of monitor. If it's over 4, then we go to the next step. But anybody want to talk about the PSA test? Is there any difference between ethnicities? I don't think so.
No.
No.
Let me just say a couple things just to that question. Me personally, I was affected, and as we all have been affected with family members who have prostate cancer. I had a bit of a scare back in the spring in March of this past year, where we speak of the PSA. I get my PSA checked every year. My PSA is generally below 1.4, 0.6, and my PSA went to 4. And my primary care, and it was just a routine check, my primary care was concerned. And he said, see a urologist and a cancer specialist. So I ended up going to Fox Chase Cancer Center here in Philly. I also spoke with the urologist. And when it comes to PSA, you check the free PSA and also the PSA. Okay, so those two numbers can direct you towards which, is this something that's just BPH where your prostate is enlarged, or is this more going down the road of, look, you need a biopsy? The other thing about the digital rectal exam is if a physician feels nodules, for sure, you're going to be recommended that you get a biopsy. Okay, so do you need to get the digital rectal exam? No, you don't have to, but you should. Number 2, the PSA, yes, you need that checked. And if there's high suspicion, family history and things of that nature, you need the free PSA and your PSA number, and they don't vary between races or anything like that.
The other part with the PSA is it's also important to make sure that people recognize it's not a one-time test, because if you went from a normal number to another normal number, say you had a 0.4, 0.6, and you jumped up to say 2, that rise in itself could be something that's worthy of concern, even though it's still within the normal range. So that's why it's important to make sure that you're getting your test done annually, because that jump or changes in the value could also be indicative of a problem.
Yeah, I think. Go ahead, Dr. Ford.
The other thing is, if you see just a precipitous rise like that, you got to start also thinking about other things. We know prostatitis, which is an inflammation of the prostate, a lot of times can cause that quick rise in your PSA. And I've sent patients over who they were at, say, a 1, and all of a sudden they're at a 8 or 9. Saw the urologist, took antibiotics. Next thing you know, their PSA is back down to 1. So, it's not always that if you have an elevated PSA that you have prostate cancer, but it definitely needs to be evaluated. And so that's one of the things to just, make sure you understand that.
Well, let's take the flip side of that. If your digital exam is negative, does that, and you don't do a PSA, does that necessarily mean that you're good to go, or should you still have a PSA done if there's a family history of it?
I believe
you should always. I believe you should always have the PSA.
That's
Always.
always.
Have the PSA. That's yeah.
But not right after the digital exam, because that can cause a false elevation. So
right.
Yes.
So I want to point out, you bring a very good point, Dr. Plummer. I want to point out to the gentleman out there, do not go and have a PSA done if you've had recent manipulation of your prostate, such as having had sex or anything like that. You don't want to do that because it's going to give you a false elevation of your PSA. So think about that. Now, the other thing about I want to bring up right now is that there are people that are out there that have an enlarged prostate called benign prostatic hypertrophy that may not have a large PSA. That doesn't necessarily mean they have prostate cancer. They just have exactly what it says, benign prostate hypertrophy, and it can be enlarged. But it doesn't mean that you stop there and don't keep getting checked for that. So we talked about, checking for the prostate. We talked about family history. We talked about risk factors. Okay, so what if we get a positive PSA? What do we do now? We got an elevated PSA. What do we do now? What should we tell our audience out there if they get an elevated PSA? What should they do next?
Get followed up by a urologist, because urologists are the ones that specialize in treating prostate cancer and managing the prostate. I think by that time, you move from your primary care doctor into a specialist and have that more specialized evaluation.
Yeah. And so we have so many different modalities for treatment. And hopefully we'll hear a little bit later on from somebody who's been through this process. We're going to bring him on a little bit later in the show, folks. But how do we fix it? What do we do about prostate? Do we everybody has an elevated PSA? Do we go right in and just, what do we do? What do we do once we find out we have the normal urologists do? Do we treat it with medicine? Do we treat it with surgery? Do we treat it with implants? What do we do? What are the modalities of treatment for prostate cancer? Anybody?
Well, I like to add to say that the PSA is just sometimes slightly elevated. Say it's less than 1 point or 0.8. You may want to repeat it maybe 3 months, 6 months. But if they do have, history, obviously you do series of monitoring it. And sometimes when you send to urologists, that's what they do. They monitor the level. And then if it jumps a little more, or they may order, as I mentioned before, one of those imaging tests like ultrasound, MRI. Also, I like to add, if there's a family history of breast cancer, ovarian cancer, or even pancreatic cancer, that you also can have an increased risk of prostate cancer.
Yeah, those.
So when they go to urology, they monitor it. Say if you need a biopsy, and it's a low cancer, so it's minor. There's different stages, and it's a minor stage. They may say wait and see, and they just monitor it, or the urologist may also talk different options. Surgery. Everyone thinks, surgery is the first thing, which we call radical prostatectomy, where they take the whole prostate out. But even before that, sometimes you may need if you need a PET scan, you have to stage in to see if it has spread to the lymph nodes, other parts of the body, because that could affect what type of treatment also, or even if surgery, or if it's beyond surgery. So there's different types of treatments that you can do. Radiation, external, or they can put like seeds in the prostate. That's a treatment. Or there's one that sometimes we call a special probe called cryotherapy, where you try to freeze the cancer. Then there's chemotherapy. That's usually sometimes if it may spread to more other parts of the body where chemotherapy. Then there's sometimes immune therapy. And there's also therapy that they call high intensity focused ultrasound that only kills the cancer cells. Then there's, we heard of the injections, hormone injections, for example, Lupron or other pill form that suppress the antigens like to testosterone, because testosterone does not cause prostate cancer, but it could, if you have cancer, sometimes it can fuel it. So that's why sometimes they may do those injections. So those are some of the things that we do regarding prostate cancer. So what I'm saying, you speak to your urologist, speak to, if you need to see an oncologist, make sure they give you all your options.
So before we get to that point, and one of the questions in the chat is, all right, you have a PSA that might be elevated or borderline elevated. What are the symptoms that that we should be concerned about that might suggest that we have an elevated PSA, and the limitations of the PSA? We need to go further. Anybody, Dr. Ford? I think you were going to say something. You're on mute, brother.
You want the question answered, or because I was going to just respond to.
Go ahead and respond, and then answer the question if you want to.
But as Dr. Isabell mentioned, there are multiple options for treatment. But what we have to do, as he mentioned, is stage the cancer, meaning find out, what stage the person is in. Is it a low stage? Is it intermediate? Or is it an advanced stage? And by staging, that requires to get tissue by the prostate biopsy. And once you get the tissue for the prostate biopsy, there's different, there's something called the Gleason score. And basically, if your Gleason score is 6 or below, we say that's a low grade, right? If it's 7, we say it's intermediate. If it's 8 and above, we say it's a high grade. And those high grade tumors are more aggressive, right? They're definitely more aggressive. Now, also, I think a good point that Dr. Isabell made was that you need to work a patient up to see if it has spread. Has it spread to any of outside the prostate gland? Because that determines what treatment you're going to have, right? If it's spread outside the prostate gland, most likely you're not going to have surgery,
right?
If it's localized, then you can still do probably radiation or if it's hormonal therapy or any of those other treatments. So basically, you need to get the biopsy, find out what the Gleason score is. That'll tell you whether it's a low grade, intermediate, or high grade, and then after that, that will determine which of these therapies you're able to get. Okay,
so I'm gonna ask a different little approach to this. Say, for instance, your PSA is maybe 10 or, somewhere above 4, and you do a biopsy and it comes back negative. That's the end of story?
Well, one thing I will add in terms of to that point, once you get that PSA number, the free and the true PSA, if you're going down the path of a potential biopsy, in most cases, to kind of weed out unnecessary biopsies, right? To make sure that if you're going to go for biopsy, it's actually warranted. In a lot of cases, they do MRIs of your prostate. Okay, so the MRI of the prostate will give you a score, not the Gleason score, but a PI-RAD number. So you get a PI-RAD score. So the MRI can take a look at the lesion, determine the depth of the lesion, the size of the lesion, and will give you a score. And if you get a PI-RAD score of 3, you're kind of in that intermediate range. And I think the PI-RAD goes up to 5. But if you're in that intermediate range, you still have to go forward. Now, it's up to you whether or not you say, look, let's go for the biopsy. But a PI-RAD score of 1 or 2, it's extremely low likelihood that this is going to be cancer, and the need for you to undergo a biopsy, that's something you would discuss with your physician. Okay, but a 3 or above on a PI-RAD MRI would recommend that you go for that biopsy there.
You bring up an interesting point.
I also like to
go ahead, Dr. Isabell. Go ahead.
I also like to add, you mentioned regarding what we do if we get a slightly elevated PSA. Sometimes we take it, the healthcare community, they take into consideration the life expectancy. If someone has less than 10 years of life expectancy where that more, and it's slow growing, they may die of something else. That's when they may do a wait and see approach, or someone only just has 2 years left of life because they have many other elements. So that's also taken into consideration also.
So you bring up a very good point. What is the prognosis? In other words, what is overall survivability of prostate cancer? Is it one of those cancers where is it curable? Is it not curable? Or what is the overall prognosis for, say, young versus old, or age or race or whatever? What is the prognosis overall for prostate cancer? Anybody?
Well, nowadays it's good. I mean, early detection. I mean, the word is, or the theory is, you don't die of prostate cancer, you die with prostate cancer.
Right.
Right. So it is something that, look, if you wait until you have symptoms and you're having back pain and hip, if you're having back pain and hip pain and bone pain, chances are it is spread, and this is a high grade prostate CA. That's why screening is so important. Early detection, biopsy if needed, and then you can determine what kind of therapy is required. In the old days, they did a radical prostatectomy and took everything out. Nowadays, it's all robotic, and you preserve in most cases, you'll preserve overall function as long as you're seeing a good surgeon and it's detected early, and you go down that route. So get it detected early. Don't wait for symptoms, because if you're waiting around for symptoms, you're going to put yourself behind the 8 ball. And that's what tends to happen in the African-American community. We present later with more advanced disease.
Yeah, I think that, in my father's case, he heard about, we talk about treatment of prostate cancer. He heard the side effects of the treatment. And the side effects of the treatment were, impotence, incontinence, and things like that. And so he elected not to do anything like that. Even, didn't consult with me, his own son, who's a physician. And it turns out he ended up having metastatic prostate cancer, which is pretty much unheard of these days if you detect it early. He was detected early by just a PSA at a screening health thing. But he only heard the side effects of what could happen if you get the surgery. And they still offered at that time the implants and the surgery. So I think a lot of African-American men out there say, I'm not going for that, because I can't be dealing with erectile dysfunction. I can't be dealing with incontinence. I can't be dealing with anybody going up my rear end to do a biopsy and things like that. So do you guys think that that's probably one of the biggest reasons we have a disparate, discrepancy in African-Americans? Or is it also a disparity to care that we get?
Well, I think that's one of the reasons, definitely. I think, again, unfortunately, the stigma that we have doesn't only just carry over to prostate. I mean, you get a lot of people that have apprehension about getting a colonoscopy done, and colon cancer is one of the leading causes of death in our society, period. So, again, I definitely think stigma plays a part. I think, again, when we talk about healthcare disparities, the lack of quality medical care in our communities, a lot of people tend to go to, and this is nothing to slight, an urgent care facility. However, urgent care is not a place that's necessarily going to do a routine screening PSA on you. So again, not having preventive care in place, I think that also plays a role. Unfortunately, yes, we do find ourselves in situations where we are either underinsured or uninsured. So again, that plays a role as well as far as limiting our access to quality solutions. And as I mentioned earlier, as far as bias and institutional racism, we have seen, unfortunately, that even in where we are controlling for economics, where you have groups that have good insurance that live in high income areas, we're still seeing that African Americans are not being offered the cutting edge therapies. And if you are not a person who's informed or have people advocating for you, you could get the watchful waiting, and you may not be a person who's a candidate for watchful waiting. And how do we say, no news is good news? Well, you didn't tell me to come back.
Yeah. So that just begs the question that, you know, a lot of us think, oh, we healthy, walk around, we feeling good. We don't have to go see the doctor. But this is one reason why you need to go and see your physician with routine care. And we've been talking about this month after month after month, prevention. Because if you detect it early enough, guess what? Prostate cancer is curable. There are not many curable cancers out there. And this is one cancer in the African-American community, if caught early enough, can be cured. So I say that to say to everybody out there, you know, stop giving into the stigma. I think one of our people in the chat said, you know, just get the finger test done. Get the finger test done. But again, if you don't want to get a finger test, we talked about here, then you get the PSA. I think there's a good starting point for that particular thing. I think at this time, is anything else we need to talk about before I bring on our guest and talk about his experience? Anything else y'all want to bring up?
No, I would just add on to Jedan, Dr. Phillips's point in terms of access to care, because it's also an issue with access to the appropriate care in terms of seeing a specialist or a subspecialist. You may see your primary care, they may do the PSA and the workup, but are you being referred to a urologist? Do you have a urologist that you can see within your zip code or within your area, or a urologic oncologist, right? Do you have access to those particular specialists that are vital in terms of treating this condition?
Yeah, I think to that point, Dr. Wingfield, you have to be an advocate for your own health care. You can't just go in and say, doctor, well, I don't need to worry about this now. If you have a first degree relative, you have a high risk for prostate cancer, speak up and say, I want to have my PSA checked, particularly if you're young, because the younger you are and you have an elevated PSA, the prognosis is not as good if you would say 80 and have an elevated PSA. You probably outlive the prostate cancer at that particular point in time. So I think the take-home point is be an advocate for your own health care. Think about the things we talked about. If you have any symptoms that are worrisome for you, speak up. You don't go to the doctor's office these days and just say, well, doctor, I'm here to be checked. Go on with your questions. Tell them what you're worried about. Tell them about your family history. We've talked about family history so many times on these calls that, that's very, very important, because you have first degree relatives and you have symptoms, you need to be checked. So again, anybody else have anything else to add before we bring on our guest that we have with us tonight? Any other comments before we go to our take-home messages? All right. Brother Pearson, can you bring on our guest tonight? And I will introduce him a little bit. Our guest tonight is one of my chapter brothers and a good brother of mine, Brother Kenny Kelvin, who has going to tell us about his personal experience. All of us on this call here, most of the doctors on this call have some type of personal experience with prostate cancer. But this brother here, Brother Kelvin, has lived it. He's living it now, and he's come on tonight. He's agreed to share his story with us. So without further ado, I'm going to go ahead and let Brother Kelvin talk about his experience and his journey with prostate cancer. Go ahead and unmute yourself, Brother Kelvin, and give us your story.
Greetings, brothers. My name is KC. Everybody call me KC, 22682, Bloody Tossig, Arkansas, Pine Bluff. Currently international retention chair and been active in LGG for over 25 years. I asked to come on because I talked to Brother Boykin. He was in my chapter. First of all, thank you, Brother Jedan. Brother Jedan and I go back to when he was in medical school playing basketball at Johns Hopkins. So I just wanted to share. The first thing, brothers, I'm going to ask you guys, the brothers who are on here, you need to add somebody who deal with the psychosocial side of it, the mental side of it, because everything that y'all gave was great, but the part you left out was the shock of knowing that you have something in your body that can kill you and how that affects you emotionally. Going to bed, sleeping at night, knowing that this cancer is in there. I could care less where it is on the Gleason scale or whatever. When you get that notice, and in my case, I got that notice, and a couple other brothers I know got that notice because we did blood tests. The finger didn't find anything. The digital didn't find anything, because by the time you find something with the digital, it's already a lump. But the PSA numbers went from like 1.4 to like 4. Then it went to 5. Then it went to 7. And all of a sudden you go do your blood work, and it comes back and they show you your lab work, and I'm sitting at work looking at my lab work on the computer. I'm like, wait a minute, that looked like cancer. And my doctor hadn't even received it yet. And so I was at work in the morning looking at dots on my prostate that said was cancerous and what percentage of it was cancerous. That in itself needs to be dealt with, because all of a sudden now I'm dealing with the psychosocial. I'm dealing with the emotional part of this. And that is major, brother. It's major. So being a Christian man, I get on my knees. I repeated Psalms 34:4. God didn't give me fear. So I had something to back on, but that's major. And that's what stops a lot of people from coming or trying to get to know this, because they don't want to know. They don't want to go through that. And then what do you do next? What is your next step? Yeah, that sounds great. Your primary care is the one who told you to go because they saw that your Gleason, that your PSAs have went up. But now you see this. Where do you go? Primary care then tells you to go see a urologist. I've never been to a urologist, never been in a hospital in my life. So I go see a urologist. He said, I'm going to do a biopsy. I don't know what a biopsy is. So this guy gives me a biopsy in his office, in his office with a nurse. And it was the most invasive thing I ever had in my life. He brings out this thing about this long, green, and started popping me, saying, you're going to feel pressure. I was like, what the heck? No sedation, anything. So now my fears are becoming realized. And I'm like, wait a minute. Is the cure going to be worse than the disease? And I'm thinking there's life, but then there's also quality of life. So what do? I don't have a psychologist to go talk to. Fortunately, my wife and my wife is a 12-year breast cancer survivor. She did 16 rounds of chemo, but she never had to do radiation. But we used to do the Susan G. Komen walk. And she and I, while we was walking in Philly, we talked to some people who was talking about this new therapy called proton therapy. So I go to a urologist. He don't tell me nothing about that. He tell me the seed. He tell me radiation. He tell me chemo. He names everything in the world. So I said, well, what about proton therapy? I heard about this 12 years ago. And then I talked to my frat brothers. They say, well, man, that's experimental. That might be experimental. So I go to an oncologist. I go to an oncologist that my wife had. I went to one from Johns Hopkins. I went to one in Arundel County. And I started talking to oncologists, not urologists, because urologists just kept blowing my phone up. We're ready to do surgery, or we're going to do active surveillance. I don't want to actively survey anything. If it's in me and I see it in me and I saw the image of it, I want this out. I can't sleep at night actively surveying this. Then I had a cousin who actually did the active surveillance. He went from 5 to 12. By the time he got to 18 and 19, his whole thing was red. So all of a sudden now they got to cut him out. He's still young, got a young wife, and now he got to look at a lymph node and all that kind of. We start talking about your manhood now. There's life and there's quality of life. So what do? I went to 3 oncologists, and I finally found one over to Nova Fairfax who was a proton therapy oncologist. So he sat down and said, yeah, we can cure this. 99% just as effective as radiation. Radiation was like they were telling me you can do the cyber knife. You can do Monday, Wednesday, Friday, then Monday and Wednesday, and you'll be done. But they're going to blast you with radiation, photons. They're going to blast you with light. You have the burns, the side effects, all that kind of stuff. People fall out from that. I was like, so what are the side effects for proton? None or basically none. So I'm like, okay. So I took his write-up of the Gleason scale and all that stuff y'all was talking about to 2 other oncologists. Let them read it. They were like, this guy is thorough. And they was, hey, if I had somebody to go through this. So I go over to the hospital and I said, this is what I want, proton. Then I look around. There are nobody in there looking like me. Y'all talking about the active surveillance. They had guys in there 84 years old getting proton therapy. Proton therapy, what they told me they're going to do, they put 3 pieces of gold in me, and they targeted with AI computers. They made a cast of my electronic. It was not invasive at all. And I went in there every day for 10 minutes, 39 sessions for 10 minutes. The first 5 minutes was a machine going around me, and I hated the MRI. I did an MRI over in Annapolis with some Sigma, and he put me in there with no headphones. I'd never been in an MRI in my life. After an hour, 15 minutes, I felt like I was about to bust out of there. I was having claustrophobia. I'm a bro. I don't have claustrophobia. But I'm in there at night having these fears. What's going on? No music playing. He doing with and without. I don't know what with and without mean. All I know is I'm laying up in here going through this stuff, trying to be strong, Omega strong. But then I go over to this other hospital, Nova Hospital in Fairfax. Everything is smooth. Everything. They're playing violins in the lobby. They're saying, come on in. But I still, after 39 treatments, 2.5 months. And at first I was going to go right before I went to Nassau with the brothers at the leadership. They said, hold up, we don't want you to miss anything. So coming in, because we don't want to mix radiation with the proton. We want you to get proton. The only reason that they held back on proton is if when the physicists have to come in and boresight the machine, or they have to use the machine for children with brain surgery, pediatric neurosurgeon. And they say it's so great because it only hits that and it don't go through your body. Radiation goes through everything. It goes through all your, this thing targets and it stops right there because it's proton. It's a subparticle of the atomic. Y'all know, y'all the scientists. So I sit there and I'm wondering, why is it that all these old men who coming through here have no symptoms at all? I never missed a day of work. And I was wondering, and people ask me, how did you do this? So this past Friday, I rang that bell And God immediately told me to tell my story. I told my story to LGG. I've had brothers just blowing my phone up. How can you actually get a treatment where the treatment isn't worse than the cure? The cure isn't worse than the disease. I say, bros, I never missed a day of work. I'm still playing golf with the bros after I go to the treatment. It's a totally different, like bro was saying, they don't tell you everything. And I was listening to what Dr. Lee was saying. He ran off all of the typical things that the urologists say, but they didn't say anything about proton in case I asked it. And when I asked for it, they checked my insurance. I had Blue Cross. The insurance people called back, oh, you're great, Mr. Kelvin, you'll be covered. So I could have went anywhere. I ain't got to go have it cut out. I ain't got to go have what you call my manlyhood taken. It is mental, bros. It's extremely mental. And even though I went through that, I'm on my knees on a regular right now. And after I finished, the doctor, he said, Mr. Kelvin, you can go see a urologist. He recommended me a different one because I don't want to go to that hack that didn't tell me anything about it. All he did was have people calling me like used car salesmen. We're ready to have surgery, have surgery, have surgery. That active surveillance, they wait until we do this. So then I went and talked to my neighbor. She's a biochemist at National Institute of Health. She was saying that she works on prostate and she works on breast cancer. She say 90% of the DNA that they work on are not from people that look like us. So they don't understand our body chemistry. They're not using it. She was upset about it. She's a Delta. I've been living next to her since 95. She said, it's wrong, KC. So we have a bigger problem. But the big thing is the psychosocial, the emotional part of it, brothers. That emotional part is real. I went to my church. Me and my wife changed churches because I had to convince my wife, who had went through 16 rounds of chemo, that I'm still a man of the house. I'm still strong. I'm still active. There's life and there's quality of life. That proton therapy, which nobody on here even mentioned, bro, I'm telling you right now, there's 25 machines in America. 25. There's 2 at Inova Fairfax. John Hopkins got one at their facility in DC. Georgetown got one. They got that one in Philly. But I was okay with driving over there every day because the experience was great. It was great. I lay down there, 5 minutes to do the board site. They targeted what I'll be zapped with. They played the music I wanted to hear. And then 5 minutes later, I got up and I left. And so I met with the team before we left on Wednesday, a week ago today. They cleared me. They said, Mr. Kelvin, we'll see you again in 6 months. Just to follow through. I said, do I need to go? I said, go see another urologist. I'm going to check my blood. I'm still praying. But they say this thing is 99% effective as anything else that you got out there. So I just want to share my story with the brothers because that fear factor is major. We need somebody there to talk to a person. How do you tell your family? How you tell your children that you got cancer? That you got cancer. That's why a lot of black men don't go in. And I got a neighbor right now. He said his brother got it, but he don't want to deal with it. They telling people that you catching it because you're riding on bicycles. You ain't got cancer. It's just you've been riding on your bike too much, so you got enlarged. That stuff is real. Go get checked. Check your blood. Every time you go in, as my wife say, tell them to check your blood, check your numbers, keep on top of those numbers. I got mine because I was playing golf with the bros in Tampa, got full, collapsed on the plane on the flight back, had never been in the hospital. They gave me an IV, said I was dehydrated. And so I decided then to go get everything checked. And that was in December. I had the biopsy on Valentine's Day. And it was the most invasive thing I ever had in my life. But then I went to Inova Fairfax, totally different. Unfortunately, there's none of us over there. I met about 20 dudes in there that I saw every day for 39 days. Older dudes, all of them older than me. All of them older than me. Happy-go-lucky. So I just want to share my story, bros.
I appreciate it. I appreciate that. Appreciate it, brother Kelvin. And folks, y'all can see. I mean, here's the one that's is excited and is emphatic about his treatment. And he says what I've been talking about all along: be an advocate for your health care. So we have one other thing I want to try to get in before we leave that. But before we go to that point, I want to thank Brother Kelvin for coming on and telling his story, because Black men should not be afraid to go and get checked for anything, whether it's prostate cancer, whether it's diabetes, whether it's whatever it is. Because if you don't know, you don't know. You don't know what you don't know, and lots of times you don't get fixed. And as he said, you know, insurance was a factor, but he was good. But even if you don't have insurance, still go get checked for it. So I want to take this few minutes here before I come on and tell my story about something different. I want the brothers to give their little, what are your takeaway points for prostate cancer? So the brothers here will hear about it, what they need to take home from that. So Dr. Phillips, I'm going to turn it over to you at this point and let you direct the before we come back out and talk about blood cancers.
All right. Well, as you taught us way back in the day, KC, how y'all say it in Arkansas, I-E.
Ah,
Yeah. And again, I thank you for showing strength like you always have, my brother. You've always been a leader and always been someone that has led from the front. And your transparency in talking about how sensitive of an issue that this is for you as a Black man and as a man is critical. And I think you touched on some other points. We have to get involved in research, y'all. Now, again, I'm not talking about just any research, ethical, compassionate, culturally aware research, because again, these conditions that affect us, a lot of times the research that's dictating the treatments available or made available are for people that don't look like us. So if we want to change that, we got to get involved. So the other thing that you said is critical, my brother, and we've been saying it the whole time through, mental health.
Yes.
You know, again, you talked on how do you tell your kids? How do you be a man in a way that is different than the way you accustomed to, but you still have to be a man? All of these points are places where it becomes very difficult. And when it gets difficult, those are places that people say, you know what, I'm not going to do anything. So again, y'all, we've got to listen to what's being said. Prevention costs you a whole lot less than reaction. So I know we usually end with me, but we're going to start with me, and I'm going to move now to 92. You go ahead, my brother, Dr. Wingfield.
Hey, I appreciate it. Great, bruh, KC. I appreciate that. Okay, team. Thank you for your testimony, for your words of wisdom, your example, for sure. Because that's the thing. Typically, there's a moment where we say, look, we got to take control of our healthcare. We have to be advocates for ourselves, and we have to dictate our own course. And that moment that you had on the golf course going down prompted those changes in life. So what we want from venues like this is that education to prompt us to go forward, to get checked out, get screened. If we detect these things early, everything is treatable. But if we put our head in the sand or say, oh, it's not going to happen to me, or I don't want this, I don't want that, we're putting ourselves at risk, and we're putting ourselves at a disadvantage. So early detection, screening, being an advocate, going after specialists and asking questions and becoming informed. There's so many venues to get information, good information when it comes to treatment options. And always, always, always get a second opinion. Sit down with your urologist or your uro-oncologist, but also sit down with another physician. And as an interventional cardiologist, I have no issue whatsoever with a patient going to get a second opinion. I encourage that, right? Because we practice by the guidelines, and they should be practicing by the guidelines. And if it's a one-off and they're doing something that's out of the norm, you need to know about it. So be an advocate, get yourself screened. Thanks, bros.
95, we're going to move to you, Dr. Isabell.
Thank you, brother KC. As doctors, we learn to listen to patients and also like explaining things better. Humble, proton. Yes, proton therapy is a form of a newer form of radiation external, but it's more focused. It uses positively charged particles, so probably less side effects, but it's explain things more better. Is we learn when we say external radiation, it's more focused, but it also is called proton. And personally, my grandfather passed away from prostate cancer. Had an uncle who has prostate cancer and some first cousin. So it's been hard in my family. One of the reasons why I got into primary care, because I didn't see anyone like me when we were treating my grandfather. that motivated me to work in the healthcare field. Once again, I learned from other people's experience. Thank you, brother.
'96, Dr. Plummer.
Yeah, thank you, brother KC. That was, I mean, that was a great message that you gave. It's important that that you'll be an advocate for yourself to also get second opinions. Also research the area that you go to or a cancer center. Ask questions about the cure rate, their mortality rate, how they're how many 5-year survivors they also have. That's also important too. Also, one of the things that is also important is that when you get your labs, because now people have access to their labs, if there's something abnormal, it shouldn't really be released until a physician is able to sit down and talk to you, because there's no reason why someone should get bad news from looking at their portal than from them and not from the doctor, sitting down, bringing them to the office and actually having a conversation with them. But again, thanks so much for your testimonial.
And last but surely not least, 05, there you go, Dr. Ford. Thank you, sir.
All right. Brother KC, definitely that was a strong statement to the bros. And one thing for docs, you got to talk to your patients.
Yes.
Right? You got to explain things. From what I'm hearing, it sounds like people didn't really sit down and explain things properly to you, it's just so important. So we need to just take a step back, slow down, make sure we're explaining things, especially something that's so important as talking about someone has cancer. So I think that is something. And the other big thing too, I'm glad you're here. You said you spoke with the bros at LGG. It's about also informing your circle, right?
Mm-hmm.
Hey, bruh, you get your prostate, you get your PSA yet, right? Whether it's your PSA, whether it's your diabetes, your A1C, we got to make bros around us accountable for their health and make sure everybody's stepping up. And so those are just my words. Really appreciate you coming on and sharing your story, though, Brother Casey.
And then we're going to end with 78. You go ahead, my brother. Thank you again for moderating.
My pleasure. So, brothers and guests out there, I want to talk about something that's dear to my own heart. This is also a Blood Cancer Awareness Month. And we know the 3 top blood cancers are going to be leukemia, lymphoma, and probably some of you have never heard of this one called multiple myeloma. Multiple myeloma is a cancer of the blood cells called the plasma blood cells, which live in the bone marrow. And those are the cells that are responsible for producing our immune fighting cells. And multiple myeloma is one of those cancers that is not curable, but is highly treatable. But a lot of Black folks don't know about it because they never hear about it. Again, we talk about disparities in healthcare, socioeconomic factors that contribute to multiple myeloma. Well, I'm here to tell you, I'm a physician and I have multiple myeloma. But guess what? There's no such thing as remission in multiple myeloma, but I am undetectable because I fortunately was detected early. Multiple myeloma affects Black people twice as much as white people. And Black people are more likely to be cured of multiple myeloma if it's detected. But why so many Black people die of multiple myeloma? Because of disparities in healthcare, exposures. We have genetic factors that, if we compare Black people to white people have a type of genetic translocation that makes them highly susceptible to dying from multiple myeloma. Whereas Black people may have one that's just a little bit of a problem that if detected early, we can tell you have problems with multiple myeloma and we can cure you. So, what do you have with multiple myeloma? Back pain, increased urination, fatigue, weakness, constipation, abnormal kidney function. A lot of people don't get detected for multiple myeloma until they get, guess what? During their screening, they are anemic, or they have problems with their kidneys, have problems with their liver, have problems with their heart. So, there's a whole lot of things out there about multiple myeloma, but you need to know that Black folks can be put into a state where they can live for a long time. I have other frat brothers that I'm aware of that have had multiple myeloma for many years. Matter of fact, the oldest living survivor of multiple myeloma is 25 years out. I am now been, I have been probably a survivor now for 5 years plus. Okay. I didn't have all the typical symptoms of multiple myeloma. Had I not known what multiple myeloma, because back when I was training in the mid 80s to the late 80s, multiple myeloma was, guess what? The kiss of death. Because all they could do was blast you with high dose cytoxin and other chemotherapies. And if you didn't die from the effects of the chemo, you died from the infection that you got from having the chemo on you. So when I was told, my story is that I was having recurrent hives. I had a real bad episode of hives, and I'm gonna try to get as fast as I can. Episode of hives when my parents came, my mother came to visit me one Christmas. Make a long story short, I kept having recurrent hives. No other symptoms such as bone pain. I didn't have a problem with pelvic pain. I didn't have a problem with anemia that I knew about. I did have a problem with my creatinine was a little bit elevated of my kidneys. But so I went to see an allergist, and part of their workup is they do a protein electrophoresis. And guess what? She called me and said, and we're good friends, she said, Keith, I don't want you to freak out like Dr. Wingfield and some of the others talked about seeing your lab before your doctor does. So she said, I want to call you now and tell you, I don't want you to freak out when you see your labs. Make a long story short, I looked at my labs and it has something called Bench-Jones protein, and that is pathognomonic of multiple myeloma. So I was watched for several months, and then I was lucky enough to be referred to the National Institutes of Health and National Cancer Institute and got involved in a study. The brothers talked about get involved in studies. We as Black people, because Black people, we can be cured of it. Our 5-year survival rate is much higher than non-African American or Caucasians if we just get access to and know that we have multiple myeloma. So this month, Blood Cancer Month, multiple myeloma, which I am a victim of, I have now completed chemotherapy in this National Institute of Health. And this past June, I was 1 year off chemoimmunotherapy. I just had a checkup on Monday, and I still remain non-detectable for multiple myeloma. So I say to you, don't take Blood Cancer Awareness Month lightly, because Black Americans are affected by multiple myeloma and they die because they don't know to go get checked for it. So I appreciate everybody hearing my story tonight. There's much more I can tell you about, but we're running out of time, and so I can't go further than that. I appreciate all the brothers being on the call. And once again, every month we have these seminars, these webinars. We talk about preventative health and things that affect the Black community. At some point in time, I may come back and talk to you more about multiple myeloma, but it is real. Leukemia and lymphoma are those some of those are treatable, some of those are curable. Multiple myeloma is not, but it doesn't faze me. Like Brother Casey said, you think about, oh my God, I got cancer. You hear the word, the C word. But I said, if I can get in this study, if I could do one thing to cure one other Black person, then I've done my job. So with that, I want to say to you, thank you for being here tonight. And please come back next month when we come again. As always, thank you for all the brothers. Thank you to our district representative for allowing us to do this. And thank you for all the leadership that has allowed us to put these programs on tonight. And I thank you, Dr. Phillips, for allowing me to have that opportunity to speak tonight. Thank you. All right, folks, that's